Welcome to the final lecture over drugs affecting the endocrine system for this course. We're going to cover two chapters within this outline, and we're talking about women's health and men's health drugs. Starting off with women's health drugs, which is chapter 34 in your book. A few of our objectives, again, understand normal anatomy and physiology of the female reproductive system. Describe the normal hormonally mediated feedback system that regulates the female reproductive system. As far as describe the variety of disorders, we're really only going to touch hard on menopause and then a little bit on osteoporosis. We're not going to get in-depth into infertility issues or anything of that nature. So this is going to be a fairly superficial lecture as far as it comes to disorders. We are going to talk about the rationale for using some of these drugs, indications when they're appropriate for use, when they're not appropriate for use, and kind of the big things that, some of these drugs you may or may not work with depending what field you go into, but there's a few basic things that you should probably understand about them, even if you don't intend on working within women's health. And that's what we're essentially going to hit on during this lecture. So to start off, estrogen. What is it? Well, estrogen, and the way I have your notes set up, just as a tangent, is going to be a little bit different than the way your book has it set up. I tried to, instead of, it'll just be a little bit different. So if you're reading your book and following the notes, you might see that the information isn't exactly as aligned. It's the same information, just in a little bit different order. The way I have this split up is we're going to talk about estrogen and then progesterone, and we're just going to talk as estrogen as in a drug. So when you take your exam, you're not going to see like estrified estrogens, Estritab as a drug. You're just going to see estrogen. So just the term estrogen is going to cover any name that you might need to know. But anyway, digressing back onto our outline. Estrogen secreted via, it's an adrenal cortex thing, and there's actually three major endogenous estrogens, and we typically refer to these as steroid hormones. They're estradiol, estrogene, and estradiol, and they all act similar, but there's a few fine differences between them. For what we need to know, though, we're just going to group them into one class and call them estrogen. Now you will see this term conjugated estrogens every once in a while, and the brand name for this or trade name is Premarin. The conjugated estrogens is simply saying that's a mixture of those three types of estrogen. They find that having the mixture seems to work the best for most people, so you'll see Premarin is widely used when it comes to the estrogen world. Kind of a side funny story to help you remember the trade name. It was created based on pregnant mares, is what they were studying when they created this medication. And the amount of estrogen within this pill is the same concentration of estrogen as a pregnant mare would have in her urine. So hence the name pre-pregnant mare, so Premarin, if that helps you remember it or not. But that is where this comes from, which is kind of funny. As you can see, there's quite a few different names. I have them listed on your outline. There's Premarin, which is the most common, but then there are a few of the ones like the depot-estradiol. Is simply referring to a depot injection, which means it's going to be a longer acting intramuscular thing. How this typically works is they'll start a patient on one medication for hormone replacement therapy, and if that one doesn't work for some reason, they have side effects, upsets their stomach, they don't want to take it, then they'll just switch to another until they find one that works for the patient. But essentially they all act pretty similar to each other. Routes of administration, there's quite a few different. There's oral pills that patient can take, little tablets. Also comes in a cream to treat vaginal dryness associated with menopause. And then it can come intramuscular for a longer acting medication. The mechanism of action of estrogen is fairly simple. It simply stimulates the synthesis of nucleic acids and proteins, which then builds new tissues. I don't know why I have insulin there. That should be exogenous on your outline, exogenous estrogen, not insulin, is stimulating receptors after the hormone estrogen becomes deficient. I proofread this 3 times and I didn't catch that till now, so I apologize there. So just cross out under number 1 for mechanism of action. That should be exogenous estrogen. We're talking about estrogen, not insulin. I apologize there. Anyway, essentially what happens when a woman goes through menopause, the estrogen becomes deficient in their body. So we're simply going to give the estrogen back to that patient because it has quite a few protective functions within the body. So women who go through once they go through menopause are at a higher risk for quite a few different disorders. A few of the tissues which have quite a few estrogen responsive receptors on it include the genital organs, the ovary and uterus, and then the breast tissue, pituitary gland, and the hypothalamus. Essentially, when these receptors are stimulated wherever they may be, they either directly or indirectly initiate the menstrual cycle or menses. Not that our replacement estrogen is going to do that, but that's what natural estrogen would do in a younger woman. Once a woman goes through menopause, though, we don't really reverse that. We don't give them back a menstrual cycle, so don't think that. Estrogen is also responsible for breast development, and that's why you'll see one of the side effects is breast tenderness, and then the redistribution of body fat and softening of the skin. Now, where this is going to get interesting is on everything that estrogen does. And I once heard a speaker describe estrogen in this way, that diamonds are not a woman's best friend, that estrogen is. And I didn't really have a good understanding of what this medication did until I went back to school and had to attend or got to attend a few more conferences. But estrogen has over 300 functions within the body. So I just pulled out some of my favorite functions of estrogen. Starting at the top of the body with the brain, estrogen is important for memory storage. So there's a theory that once a woman goes through menopause, she's at an increased risk for Alzheimer's disease. So one of the reasons for giving a hormone replacement therapy is to help prevent that loss of memory and onset of Alzheimer's, which is kind of weird. More importantly, and why most people, or one of the bigger reasons why people go on hormone replacement therapy, is for the cardioprotective functions estrogen has. Estrogen is a potent antioxidant which helps prevent against cancer, among other things, but then it's also a vasodilator. So sometimes women will develop hypertension after going through menopause because they no longer have the estrogen dilating out their vessels to keep their pressure low. The next biggest reason why people elect to use hormone replacement therapy has to do with the next bullet point there, the bones. One of estrogen's functions in the body is to maintain bone density. So once a woman goes through menopause and loses that estrogen, they don't have the osteoblast formation anymore, so their bones are breaking down, but they're not rebuilding. Replacing estrogen helps stimulate new bone growth or preserve bone growth, so therefore it helps protect against osteoporosis and fractures. That'll be a big thing as we kind of go through here. Similarly to bones with the teeth, if you have good, strong bones, teeth are kind of an extension of that. So it helps retain your natural teeth or the patient's natural teeth by keeping them on an estrogen supplement. And then the thing that's very superficial, yet people are really worried about or care about, is within the skin. So estrogen has to do with keeping collagen formation underneath the skin, which is kind of the fatty layer that prevents wrinkles. So by taking estrogen during menopause, there's a thought that it can help prevent wrinkles. Now, there was a study, and how big it was, I don't know, or how valid it was, I guess I'm not really sure either, but there was a study, and women actually took their Premarin vaginal cream that's supposed to be inserted vaginally, and they rubbed it on their face instead, and the study said that women looked on average 5 to 7 years younger than their stated age when they used their Premarin cream as a face cream instead of a vaginal cream. So if you know somebody in your life that's really concerned about it and they're willing to do this, they can give it a try. 5 to 7 years is pretty significant, so I guess whatever floats your boat. The next one's bladder. Another thing that estrogen does is it helps keep E. coli out, and it does that via keeping the urine acidic. So once a woman goes through menopause, their urine becomes a little bit more basic, which means it's not as great of a mechanism for fighting off UTIs. So in addition to everything else, a woman's risk of developing a UTI after menopause increases because they lose their acidic urine, and E. coli just invites itself right in. And then, of course, one of the more annoying but not life-threatening things that menopause induces is decreased vaginal lubrication. So people complain of dryness, and that can become an issue if they're still sexually active. It can make intercourse very painful for them. And although it's kind of uncomfortable to talk about at first, it is a big part of people's life and certainly something you want to address the patient holistically. And it's kind of a blow to a woman's self-esteem. You lose your collagen, so you get wrinkly, your bones are brittle, you're getting UTIs, and now suddenly it hurts to have intercourse. It can just be a lot of psychosocial stuff. Plus, when you go through menopause, it makes people very moody. So just be sensitive if this happens to be an area you work in or go into. And just, I know it can be uncomfortable, but we'll get over it because that's what nurses do. One other bonus to having an estrogen replacement, though, is it also keeps your waistline slender. It's shown to decrease the amount of visceral fat, so it keeps that nice hourglass figure, which is kind of nice. So lots of reasons to go on hormone replacement therapy. As far as the indications for taking estrogen, obviously to treat an estrogen deficiency. Now this can be either through menopause, which is just a natural thing women go through, or it can also be from women who have a removal of their ovaries via hysterectomy. You don't see when they do a hysterectomy, they typically don't remove the ovaries unless there happens to be cancer or another pressing reason to do so. Otherwise, say a woman has a hysterectomy because she has heavy menstrual bleeding or for whatever reason that's non-life-threatening, so it's more of an elective thing. They'll normally take the uterus out, but they leave the ovaries so that she's still producing natural estrogen. If they take the ovaries out with that hysterectomy, though, it will take away her ability to produce estrogen, and then they'll go through menopause earlier than what a woman normally would. And then all these clinical manifestations, the osteoporosis, cardiovascular disease, that would all set in quicker. Another time that they might have estrogen deficiency is women who go through chemotherapy or radiation therapy. Typically, those drugs also induce menopause. So even if you go through cancer treatment in like your 20s, your body will still probably go through menopause as a side effect from those chemotherapeutic agents. So that might be another time somebody has an estrogen deficiency. What we call, just kind of as a catchphrase for estrogen, is hormone replacement therapy. We call it hormone replacement therapy for a couple of reasons. One, estrogen is a hormone, and sometimes we're talking about just estrogen, and sometimes we're combining it with progesterone, which we'll talk about in a little bit. The reason why people elect to go on hormone replacement therapy, whether it's just estrogen or estrogen and progesterone, is to help minimize menopause symptoms. There's some that just decrease quality of life, and there's others that are actually quite life-threatening. When estrogen is used for hormone replacement therapy, though, it's important that the smallest effective dose is used to minimize side effects. Some of the side effects of menopause now, not estrogen, but of menopause that estrogen is going to treat, include some of the mood disturbances, depression, irritability, insomnia, hot flashes. It helps regulate what menstrual cycles they have left, so it's not a surprise when they're going to come. It helps relieve headaches, stress, incontinence, and then skin atrophy. So those are typically the reasons which cause women to seek out hormone replacement therapy. But in addition to those reasons, which are completely valid, estrogen or hormone replacement therapy also helps prevent some of the long-term consequences of menopause. And the biggest two that are really proven and we know they do a good job with is cardiovascular disease and osteoporosis. We know replacing estrogen right around the time women go through menopause is going to decrease the risk of developing cardiovascular disease and decrease the risk of developing osteoporosis because estrogen naturally protects you against those diseases. And again, there's thought, because it's working on that acetylcholine in the memory, that it might help prevent against dementia, and same thing with colon cancer. Estrogen's thought to protect you against colon cancer. You're probably thinking, this sounds like such a phenomenal drug, why doesn't just everybody go on it? But although it's really good at what it does, there are some pretty significant side effects, which we're going to get to in a few minutes. Other reasons why people might be taking an estrogen of some sort include an oral contraception, or if they have problems with dysfunctional uterine bleeding. Sometimes estrogen will be elected to be a treatment to help relieve that as well. Another little side note on hormone replacement therapy is an FYI, it can be abbreviated to HRT. So when you see HRT in your notes, that's what I'm referring to. Use the lowest dose so that we don't induce side effects, which we're going to talk about in a few minutes. And then I've got the osteoporosis and cardioprotective effects there, so make sure you know that again, that's a big reason why people elect to go on estrogen. And then I have their estrogen therapy should be continued no longer than 10 years after menopause symptoms start. Don't hold me to the 10-year rule, because I don't know if that guideline has changed. What I do know is there comes a time after menopause that we don't want women taking estrogen, because suddenly the side effects of estrogen will outweigh the benefits. So just keep in mind, hormone replacement therapy isn't a long-term. It's long-term in the fact they might be on it for up to 10 years, but it's not a forever treatment. Eventually, we do need to get them off the estrogen, because it does have some pretty significant side effects associated with it as well. So a few of the contraindications to hormone replacement therapy. And now that I've made this drug sound so miraculous, I'm going to let you in on the secrets as to why it might not be so miraculous. The first real reason I want to point out is that women who have estrogen positive cancers, or estrogen receptor positive cancers, should not go on hormone replacement therapy. And this is one of the reasons why sometimes women will elect not to go on it, because you don't really know you have cancer until you get diagnosed with it. So you could have a tumor, or you could be more susceptible to developing an estrogen receptor positive cancer. And then if you started taking estrogen, it would speed that along. So sometimes women will say, cancer runs in my family, I don't know that I'm willing to take the risk. The two types of cancers that tend to be estrogen receptor positive are breast cancers and uterine cancers. And once somebody's diagnosed with breast cancer, they'll test it. And when they test the type of cancer, they almost always come back of if it's BRCA negative or positive, and then if it's estrogen positive or estrogen negative. If it's an estrogen negative cancer, then estrogen therapy would have no effect on it. But if you give somebody that has an estrogen positive cancer estrogen, it stimulates the growth of that cancerous tissue, so then it progresses that disease along quite quickly. So that's the first really big contraindication. The next one, pregnancy. If you're pregnant, you're probably not going through menopause, so this probably isn't something that is going to happen. But estrogen is a Category X drug. It will induce an abortion or a miscarriage, so it is contraindicated in pregnancy. And then the last one is the risk of bleeding disorders. And the type of disorder that happens is it does increase your risk for clotting. Now, some people will have a higher risk. If you don't have a history of bleeding disorders, of clotting disorders, it's probably not going to affect you. It's the women who already have a risk for clotting. And there's certain diseases that increase your risk. And then also if the patient is a smoker, that will increase their risk for developing a blood clot as well. As does sedentary lifestyle, being a diabetic. There's a couple of other comorbidities too, but women who are at a high risk of developing a clot, we typically do not use estrogen as a hormone replacement therapy, just because it increases it a little bit more. Now some of the adverse effects here. Some of them are pretty mild, like the nausea isn't going to bother anybody. But then the thrombophlebitis, so it destroys blood vessels. It has the potential not necessarily to destroy the blood vessels, but to induce clotting. And again, it's more so if the patient has other risk factors which already predispose them to it. The next term there, the chloasmia. This is a skin condition, and what it looks like is just a little brown macular spot, but it tends to occur on the face. So it does detract a little bit from people's image of themselves. And that can be, some people it doesn't bother, and some people find it really disturbing. So that's another side effect of estrogen. Hair loss, and then also secondary like male characteristics, the voice might deepen a little bit, can also occur when you go through or take estrogen, which is kind of weird because you would think it'd be the other way around. The tender breasts, fluid retention and edema. And then the last one is the reason why a lot of people who still have a uterus will elect not to use estrogen as a hormone replacement therapy. And the guidelines that existed once upon a time, and again, I don't know if this has been updated or not, because they change these like yearly. They change them all the time. It used to be said that if a woman still had her uterus, so she hadn't had a hysterectomy at some point in her life, that she needed to be on estrogen with progesterone to protect her uterus. Now, if she had a hysterectomy at some point in her life, then it was safe for her to use just estrogen. But one of the big things estrogen is really good at is stimulating growth, stimulating tissue growth. And within the uterus, the endometrial tissue, it's really good at stimulating cancerous growth. So progesterone will help stop that side effect, but estrogen just by itself will stimulate a lot of that endometrial growth, and therefore patients sometimes, due to the risk of having an endometrial cancer, will opt not to use it, or physicians will opt not to prescribe it due to that risk because it might not be beneficial for the patient. Normally, just to be safe, if somebody wants to do hormone replacement therapy and they've never had a hysterectomy, they'll get put on estrogen with progesterone, again, to protect their uterus a little bit. The interactions with estrogen, I just pulled out a few that you might kind of recognize here, because there certainly are a lot more listed in the book, but just trying to build connections on what you've already been taught. The first thing is it will decrease the activity of oral anticoagulants. So if somebody's taken, say, like Coumadin or Rivaroxaban or Xarelto to prevent, or even aspirin to prevent a blood clot, and then they start taking estrogen, it's going to decrease the activity of that anticoagulant. What this means for your patient is it's going to increase their risk of clotting. So then they're going to be at a higher risk of developing a MI, or having an MI, a PE, a pulmonary embolism, a stroke, something of that nature. So that's kind of a big interaction. The next one has to do with antidepressants, and when estrogen's taken with somebody who's taken a TC antidepressant, so say Ealavil, it'll increase the risk of developing TCA toxicity, which, remember from the chapter we covered a couple weeks ago, 50% of people who develop TCA toxicity die before they ever hit the hospital. So that's kind of another big thing. And it's only with the tricyclic antidepressants. It doesn't work. It doesn't interfere with like your SSRIs or your SNRIs, or it doesn't appear to so much. And then, of course, smoking increases the risk of clot formation, which is another interaction that we encourage patients not to smoke while they're on estrogen. So here's just a little natural thing for your day, because some people do like to take a natural approach, and that's certainly okay. And some natural remedies have a lot of validity in today's world, and I kind of think they're underused. So just going to expose you to this one, black cohosh. This is a perennial. It grows within the United States and Canada, and it's been used for centuries by Native Americans, Alaskan people, Eskimos, Pacific Islanders, a lot of different tribes or ethnic groups have used black cohosh to help decrease the side effects associated with menopause, particularly hot flashes, vaginal dryness, and night sweats. Those are the big things it works with. Now, the one thing that we do need to be careful about if patients are using black cohosh is one of the side effects of it is hypotension. It lowers the blood pressure, which isn't a bad thing unless they're taking medications to also lower their blood pressure. So if they're on an antihypertensive and they're taking black cohosh, they run the risk of dropping their blood pressure too low. So that would just be something to kind of be aware of if somebody asks you if it's safe or not. It is safe, but make sure you tell your doctor, because we do have medications which will interact with it, and we just need to be aware. Okay, the next hormone we're going to talk about is progesterone or progestins. The drug you'll need to know for this section of the lectures, medroxyprogesterone, also known as Provera or Depo-Provera. Now, what progesterone does in the body is it inhibits the secretion of FSH and LH. So those are going to be your reproductive hormones. If you think back to, I think it was chapter 30, we kind of talked about what each hormone did. So now we're going to inhibit the secretion of the reproductive hormones. So this will largely be used in a contraceptive manner. In fact, that's one of the biggest things is it prevents follicular maturation, ovulation, and stimulates the growth of mammary tissue. Not that that has a lot of clinical significance to us, but this will typically pop up within oral contraceptives. Regardless of your feelings on whether or not contraceptives are ethical to use, because some people don't, and that's certainly okay. The only thing you need to recognize is that you will probably care for patients who elect to use them, and you still want to, even if you don't necessarily agree with their lifestyle or what they're doing. As nurses, we still have an obligation to provide compassionate care. You certainly don't have to validate lifestyles you don't agree with, but you do have to provide respect to persons and dignity of care. So that's why we cover this. Not that I'm trying to convince anybody that this is okay, but there are just a couple things that you'll want to know about contraceptives so that you can provide safe care to patients. So just with that in the back of your mind as we move forward, I'm certainly not trying to advocate one way or the other here. Just a couple facts here. The other thing with progesterone that has nothing to do with contraceptive is sometimes they'll also use this as an anti-neoplastic medication, so as a chemotherapeutic against endometrial cancer. Remember I really want you guys to remember this. Progesterone or progestins, Provera, all those medications or hormones protect the uterus and they protect that endometrial lining. So that is one thing that this drug certainly has going for it. Indications, it will sometimes be used for women who also have dysfunctional uterine bleeding for whatever reason. It can be caused by fibroids, cancer, it can be genetic. Can also help treat primary and secondary amenorrhea, and then again as a contraceptive. Also, as I mentioned before, it can be used as an adjunct therapy to hormone replacement therapy. And the reason why it's added to estrogen and hormone replacement therapy is, again, to protect the uterus. And that, I would say, is probably one of the more common uses for progesterone. So a couple of the contraindications, they're going to be kind of similar to estrogen. If somebody has an increased risk for clotting, we don't really want them taking progesterone either because it will increase the risk of clots just a little bit more. What it does is it decreases the clotting time, so it increases clot formation. So in a healthy person, if it takes you 18 seconds to form a clot, these patients are forming their clots in 10 seconds. So it's just forming quicker, and then they tend to travel better too. Also, women who have had an estrogen-positive cancer diagnosed, we normally avoid this. I don't believe there's a hardcore correlation with it, but they still tend to avoid this drug. And then the side effects. The one that's a little bit different from estrogen is going to be the liver failure. Progesterone could even be contraindicated in people who have hepatic failure. So liver enzymes will be watched and liver functioning will be watched while they're on this. It's not terribly common, but common enough we'll acknowledge it. And again, thromboembolic disorders, increased risk for clotting. What you're not going to see over here, though, is going to be like the uterine cancer. It doesn't cause, the endometrial cancer at all. Okay, so here's just a little trivia for the day on fertility drugs to lighten the mood just a little bit. So you can put your pencils down. Please don't write this down. I promise it will not be on the test or anything, but there's this fertility drug, and it's called Clomid. It was discovered by a medical student in the 1960s. His name was Bruno Leuenfeld, and he made the connection that FSH is a hormone needed for ovulation and fertility. So oftentimes women who are having infertility issues have low FSH levels. So they were working on a project to try to figure out, well, how could we increase that At this time, there wasn't any synthetic FSH, so they were trying to figure out, well, how do we get it? He also recognized that women going through menopause tend to have really high levels of FSH in their urine. So now we're back to the urine. We talked about it with pregnant mares, and now we're going to talk about it with women who need to get pregnant. So he had this idea, well, could it be derived from urine from women going through menopause? And why, yes, it can. He established it can be done, but then the next problem was who's going to donate their urine, because it has to come from a very specific population. It must be a woman, and more specifically, it has to be a woman going through menopause. He actually convinced nuns to donate their urine during their menopausal years to promote the fertility treatment, which is kind of unique, kind of cool. And that will be all the more I have on fertility medications for you. We're going to deliberately step over that section in the book because you're going to cover it more in depth when you take OB courses through whichever program you elect to go through. And it's probably not real necessary to go in depth at this point. So that's your only story on fertility treatment. Now, the next topic is going to be osteoporosis, and this is something that, again, you're going to deal with, and there's a few things we need to know about it. You've probably already been taught who's at risk, but if you need a little bit of a refresher, women are at a higher risk than men. Women of Caucasian or Asian descent and men of Caucasian and Asian descent tend to be a little bit more at risk, and people who have a small body frame. Also, people who do not do weight-bearing exercises, so people who don't weight lift, are also at a higher risk for osteoporosis, because one of the things with pounding the pavement or pounding on your bones a little bit actually builds them in strength. Then the older you get, the more at risk you are. If you're a smoker or if you follow a diet that's high in alcohol and low in calcium, those all place you at risk for osteoporosis. And it's kind of one of those things that if you live long enough, your bones they stop rebuilding after a while. So unfortunately, it's just kind of what happens with life. But we do have some stuff we can do to help delay the onset of the disease and help prevent it a little bit. There's 3 different drug categories that we're going to talk about. I believe your book lists 5, but what I did is I just went through and I pulled out the 3 more common ones. So again, you're going to see me deviate from your book just a little bit in the outline of the notes, but I think it'll make more sense for you as we go through here. The first category is the bisphosphonates, and the one you'll need to know from here is Fosamax. So for all these little slides here, we're just talking about Fosamax. That's the only drug from this category you need to know. How it works is it inhibits osteoclast-mediated bone reabsorption. So it's inhibiting the bone reabsorption, which enhances the bone density, prolongs the life of the bone. It's indicated for the prevention and the treatment of osteoporosis. Now, this is where this medication gets a little bit more exciting, because most of our medications are only going to be for prevention. So the fact that we have a medication which can actually reverse this disease to a certain point is really, really exciting. And I want you to make that little note there. The Fosamax can actually reverse the disease a little bit. Not 100%. It's not going to give you the bones you had in your 20s when you're 80, but it is going to help stabilize and build up some bone density. So that's really exciting about this. For the most part, it's really well tolerated. The only really significant side effect with this is the esophageal irritation, which we take a couple of steps to help prevent that from occurring. Now, the steps that we take to help prevent the esophageal irritation from occurring have to do with how we administer this medication. This is one where the patient needs to sit upright for 30 minutes after they take it. By sitting upright, it keeps the medication via gravity towards the bottom part of the stomach and away from the esophagus. If you take this medication and lay back down, it's just going to, via, again, gravity, kind of roll back towards the esophagus, and then that can cause erosion. And you'll see, like, if you do a clinical in the hospital and you give Fosamax, they write right on the MAR, make sure they sit upright for 30 minutes. And if you happen to catch this commercial on the TV as well, you'll hear them enforce that as well. Make sure you can sit or stand for 30 minutes after taking the medication. The other thing we do is we avoid calcium-based foods and Tums for 1 hour before and 2 hours after. Now, this particular bullet point has nothing to do with the esophageal erosion. What that has to do with is it just, calcium will bind to Fosamax, and then it just gets excreted so it doesn't get absorbed. So we just don't want to take it at the same time as a calcium supplement because it won't get absorbed. The last bullet point also has to do with protecting the esophagus, and that's just to drink it with a full glass of water. And the thought there is if you have a full glass of water, you get washed all the way to the bottom of your stomach, and it's not going to get lodged anywhere near that esophagus. A few more plugs for this drug as to why it's a good drug. Can reduce the risk of hip fractures up to 51%, and can reduce the risk of spinal fractures up to 47%. So one of the big things when people get older, a simple fall, a simple trip, and a hip fracture can end a person from living within their home. And we see it all the time. Somebody falls at home, they have a hip fracture, now they get admitted to the nursing home, and they don't get to go back to that lifestyle for which they were used to. And that can be a pretty life-changing event. So if we can prevent that from happening, because most people don't, most people want to stay within their home as long as possible, and our goal, if it's their goal, is to keep them there. So if we can decrease the risk of developing a fracture, that is awesome, and that is really going to help preserve people's health. Another thing, once a bone gets fractured, the older you are, the longer it takes to heal, and these patients tend to lay in a hospital bed for more time than a younger person would, and the longer that person is immobile with their fracture, the higher risk of developing pneumonia, bed sores, a whole host of conditions, blood clots, all that stuff. So if we can prevent them from fracturing, that's a really exciting thing. So Fosamax is really, really not a bad idea for grandma to get on there. The next group we're going to talk about are the selective estrogen receptor modulators, which is abbreviated SERM. And the one you need to know from here is Evista. Evista is working similar to your natural estrogen or to natural endogenous estrogen, and all it's doing is stimulating the estrogen receptors, but it's specific to the estrogen receptors within the bone. So therefore it's a little bit safer. It increases bone density in a similar manner that endogenous estrogen would, and it's indicated for the prevention of postmenopausal osteoporosis. So again, this is going to be a preventative thing. Once the disease of osteoporosis is set in, this isn't going to reverse it, but it can help prevent women from having that sharp decrease in bone density as they go through menopause. They can elect to take this instead of hormone replacement therapy if they would like to, but keep in mind if they can't take estrogen for whatever reason, they probably shouldn't be on this either. There is a correlation if they've had an estrogen-positive receptor cancer. There is a correlation that this could potentially, a lot of what we do is could potentially increase the risk of that as well, so a lot of times they'll say no more. Some of the side effects associated with Evista include hot flashes. Now this is one of the reasons why patients would almost rather be on estrogen with all of estrogen's side effects than Evista. If you tell a woman who's already going through hot flashes and menopause that you're going to give her a medication that's going to increase her hot flashes, she's probably not going to take it. They're really miserable for women to go through, so therefore that side effect right there that I'm making you write down is a big reason why women go off this medication and they don't want to take it anymore, because the hot flashes were already unbearable, and then they take Evista and now they're like, whew, go jump in a snowbank, it's so hot. So just keep that in mind. Also can cause some leg cramping, which wakes people up in the middle of the night, increases the risk for clotting. However, one of the good side effects of it is it does help lower cholesterol. So that's kind of exciting for women. Or men if they were to take it. I don't think a man would take this though. That doesn't sound like a very good idea. Okay, the last group that I have to talk about when it comes to osteoporosis is calcitonin. In this one, if you were listening closely to chapter 30, it was listed in your outline as it's working with the thyroid, actually it might have been chapter 31, but it works with the thyroid gland to regulate serum calcium levels and bone density levels. And all they figured out is how to isolate that hormone and then turn it into a drug. So calcitonin directly inhibits osteoclastic bone reabsorption. So it's preventing, they say it treats it, but it's more so preventing osteoporosis from occurring. Once the disease is underway, it treats it a little bit, but it's more optimally taken as a preventative measure than as a restorative measure. So yes, you can use it to try to treat it, but it's better if you're going to prevent it. Side effects of this are going to be very mild, some facial flushing, nausea, perhaps some diarrhea, but nothing that's real terrible. And then just a quick note on Pitocin or oxytocin. Oxytocin is another hormone. It's a natural hormone secreted by the posterior portion of the pituitary gland, and it's used to induce labor. And that's essentially what you need to know about it right now. Associate oxytocin with reproductive and associate with inducing labor. When women come in and they need to be induced, this is the drug that they'll hang. They'll hang it via an IV, and they'll titrate it, and they'll get that labor going. In addition to inducing labor, it also causes milk to be ejected. Some of the side effects with this, though, and why it has to be monitored very closely, has to do with that fetal bradycardia. So they'll have a fetal heart monitor on the mother while she's getting her Pitocin infusion. And when you go through your OB courses, you'll learn that that's a really big thing, that they monitor the baby's heart rate to make sure that the child's not in distress. Also, if a woman gets too much oxytocin and it causes that uterus to contract too much, it can cause a uterine rupture, which then typically results in a hysterectomy. So it does need to be monitored. It's a good drug for what it does, but it does need to be monitored. And then if labor progresses too quickly and they need to slow it down, they will hang magnesium. So they'll do a Pitocin or an oxytocin magnesium balance to progress labor but not progress it too much. And if somebody comes in preterm labor and they need to stop it, they'll just give a magnesium to stop it. Okay, so that's kind of the nitty-gritty of what you need to know about women's health drugs. Again, a lot of it has to do with estrogen, with clotting. It's good to prevent osteoporosis. It's good to prevent some cardiovascular diseases, but it does increase the risk of that uterine cancer and also of clotting issues. And then we always want to prevent osteoporosis, so we encourage people to get on some Boniva or Evista or something of that nature. The next chapter we're going to talk about is men's health drugs, which is oh so exciting. Just hang on to your seat, you will be excited. So just a few objectives. We're going to talk so very quickly about the functions of the male reproductive system, compare various men's health drugs, describe mechanisms of action, and just I'm going to tell you what you essentially only what you really need to know about these drugs. Again, unless you go into a very specific part of nursing, I'm just going to introduce you to what you'll need to know as a general nurse. So we're going to talk about the third corticosteroid stimulated by the adrenal cortex, and that's going to be the androgens. And most specifically, we're going to be talking about testosterone. Now, testosterone is responsible for primary and secondary male sex characteristics. So it's essentially what makes a man look like a man, and it also helps drive their reproductive health as well. It's secreted from the adrenal cortex, in addition to contributing to secondary and primary sexual characteristics. It also helps in the development of bone formation, and it inhibits protein breakdown. Now, the fact that it inhibits protein breakdown, and does a couple other things, like it suppresses nitrogen decomposition, and it also stimulates the secretion of erythropoietin. Those effects of testosterone is what causes people, I should say, to sometimes abuse testosterone and use it as an anabolic steroid. So now this is the type of steroid that is outlawed, or it's a class 3 narcotic drug in the sports arena. People will use it to enhance. It's a performance enhancing drug. That's what we're talking about here. Now, in addition to being a performance enhancing drug, which we're not going to give for that reason, it also has a couple other indications for men who have low functioning T levels. But just bridging it to something you might know, we're talking about the same thing there. The mechanism of action is very similar to that of endogenous androgens or testosterone specifically. It stimulates the synthesis of RNA, which helps build up tissues, particularly those muscles and endurance, which is why it's used illegally. And it also stops the breakdown of amino acids, which also contributes to muscle size. And again, stimulates the erythropoietin from the kidneys. What erythropoietin does in the body is it helps red blood cell formation, hemoglobin formation. So I'm going to pull this analogy to if you ever try to work out after donating blood, you're going to feel really short of breath. Now if you do the opposite, and if you were to increase your hemoglobin, you're going to find you have better endurance. So sometimes people take it so that they have a little bit better endurance, especially if they're traveling to a place of higher altitude where people tend to get a little bit more anemic. Administration of exogenous androgens does cause the adrenal glands to stop or reduce their normal production from the adrenal cortex. And the same thing that went with corticosteroids. If the body perceives it to be a normal level within the system, it's not going to stimulate the hypothalamus to send a message to the pituitary gland, to send a message to the adrenal cortex to stimulate. That mechanism just stays off. So then if you stop testosterone suddenly, all of a sudden the body wants to know, well, what happened? And then they'll go into overdrive. It's not going to be deadly to the patient like stopping a corticosteroid would be, but still not the most healthy thing for them either. One other thing with testosterone is it has a very extensive first pass effect. If you remember from one of the first lectures you guys listened to, your first pass effect is referring to when the liver metabolizes and disables your drug before your drug has a chance to do anything in the body. So it gets absorbed from the stomach, it goes straight to the liver essentially renders it useless and then goes to the kidney and it never reaches the tissues it's supposed to. For that reason, if somebody's going to use an oral tablet of testosterone, they need to use a synthetic form of it. And your book talks about the names. I'm not concerned that you know the names so much, just to understand that if they're using a tablet form, they're probably going to need some sort of a synthetic testosterone. More commonly, it comes in a patch or a cream or ointment. That's what most people will use to deliver it, and that will bypass the first pass effect, so it doesn't become such an issue. And then the intramuscular is typically the route people who are using this illegally opt to use because it tends to be the most potent. So people who are using their steroids to enhance their performance in the athletic arena are probably taking it IM. So indications. One could be hypogonadism. It can also be referred to as a male hormone replacement therapy for low circulating T levels, which just happens as men get older. Women lose their estrogen, men lose their testosterone. It's just one of those fun things about getting older, I guess. Also, men who are going through fertility treatment and they have a low sperm count may also get a testosterone, either injection or patch, to help induce spermatogenesis or increase their sperm count as well. Some of the contraindications for androgens. I'm not entirely sure why a woman would want to take this unless they were doing it for an anabolic reason, for a steroid reason. But women of any age really should never ever take testosterone. That's a really bad idea for women to do. Particularly though, women who are pregnant need to avoid this because this will cause a miscarriage in a pregnancy. People who have severe renal, cardiac, or hepatic disease should also use with caution. And then with men with breast cancer or prostate cancer also need to be careful because testosterone will stimulate the prostate gland to grow and become more cancerous. And you'll see one of our prostate medications that we'll talk about is an anti-testosterone, so it's actually blocking testosterone. So then if you unblock it and encourage it, it encourages the growth of that cancer. Some of the adverse effects, the main one is going to be it can cause liver cancer or liver failure, and then it does lead to a little bit of fluid retention, similar to the corticosteroids, so that can lead to hypertension or heart failure as well. The only drug you need to know is testosterone. It's the same name as the hormone, and androderm is the trade name, and all it's doing is mimicking the natural synthesis of the androgens. Now, it's delivered to, or it's designed to deliver a dose that's very similar to endogenous testosterone. So it's set up to have a higher concentration, like if it's a patch, they'll just use one patch. That patch is smart enough to release a higher dose in the morning and then a lower concentration in the evening, which mimics a man's normal testosterone secretion. So that's kind of crazy that they've taught a patch how to do that as well. But that's what it's supposed to do. As far as placement, the androderm we're talking about here comes in the patch form. I'm not talking about the anabolic steroid at all. So this is going to come via transdermal route. And there's actually two on the market. The one that we have listed here can go wherever you want to put it. Most people, I think, probably put it on their shoulder or their back, but you can put it wherever you feel like. If you want to put it on your forehead, you could put it there. Doesn't make a difference. The other one on the market, the Testoderm, must go on the scrotal sac, otherwise it doesn't work. So that's, I guess, one benefit to the Androderm is it's a little bit more user-friendly. The next two drugs we're going to talk about have to do with BPH. And just as a quick reminder, BPH is no FUN, which stands for frequency, urgency, and nocturia. So frequently urinating, quick desire, or gotta go right now feeling, and then the nighttime urination as well. This becomes an issue because men, as they age, their prostate gland just gets bigger. It's just what happens, and this starts like in the late 30s, I believe. Mid to late 30s is when it starts to enlarge. So by the time men are in their 40s or 50s, it will start to occlude their stream. Now, this doesn't always mean cancer. If it's cancer, I would have called it prostate cancer. Benign prostate hyperplasia has benign right in the name, so it's not cancerous, it's just an old age thing, which they're not even that old. As I approach 30, that's not that old. But it's what happens. So it's not unusual for a male to need some sort of help to help them go to the bathroom. Otherwise, what the prostate gland does is it occludes urine flow, and then if urine can't go out, it builds up into the bladder, and it can cause UTIs. It can cause kidney, a nephro infection. So it really is kind of a serious thing. Luckily, it's easily treated too. The first medication we're going to talk about is Proscar. Proscar is the one I was saying is the androgen inhibitor. So this is actually going to block, and not the secretion of testosterone so much, but it blocks a specific enzyme which is required for testosterone metabolism. And by doing that, it eliminates the hormone signal for the prostate to grow. So kind of like the Evista was specific to estrogen receptors within the bone, Proscar is going to be specific to the testosterone receptors within the prostate gland. Because it's very enzyme specific, it doesn't cause other androgen inhibition, so these patients don't have a loss of their lean muscle or infertility. But the drawback to this is it can take a long time to help the patient. It can take anywhere from 3 months if they're lucky, up to a full year for them to really see any relief from it. For that reason, this probably isn't the first choice people go on, but you certainly will see people go on this. If you happen to give it in the hospital setting, you'll see it comes in a green light protected container. It's okay for women to administer this, but I would recommend not directly touching any medication because that's an infection risk. But be very careful if for some reason you have to have this medication. Please put on gloves just to be safe, to make sure you're not coming in contact, because this can have some pretty significant consequences for women, particularly women of childbearing age. So just be safe. Really don't touch medications. It's not a good practice. But if you do happen to have this for whatever reason, just throw on a pair of gloves to protect yourself too. Indications, it's going to be used for benign prostate hyperplasia, and it'll be a higher dose for that. If the other indication for this is men who have male pattern baldness, can use it to help restore hair loss. If they're using it for that reason, they'll require a lower dose. Some of the contraindications to Proscar, pregnant women should by no means ever ingest it, and they really shouldn't handle it. The likelihood of them coming in contact is very minimal, but why risk it when there's enough people who aren't pregnant to administer it? is category X, and again, I can't stress enough, just don't touch it. Keep your hands to yourself. The adverse effects associated with this drug include a loss of libido for the male, erectile dysfunction, and then gynecomastia, which is all just coming from suppressing the testosterone. So if you think of what testosterone does, although this is a very specific receptor, it does have a few of those side effects associated with it. Now the next one we've already talked just a little bit about when we talked about adrenergic agonists, but we're talking more about Flomax. And again, the flow makes it go. This is the first choice medication to use for men who have BPH. I think it's a rite of passage when you turn 40, you get prescribed Flomax. It's just what happens. How it works is it is an alpha adrenergic antagonist. So it's going to suppress the sympathetic nervous system, acting specifically on those alpha receptors. By doing that, it relaxes the smooth muscle within the prostate gland, the bladder, and the urethra. By relaxing that smooth muscle, it causes that prostate gland to let go a little bit. One of the major differences between this and Proscar, besides the mechanism of action and besides how long it takes to kick in, is Flomax is not a reversible medication. Maybe I said that wrong. Flomax, if the patient goes off it, the symptoms will return. Proscar actually works to reduce the size of the prostate, whereas Flomax simply relaxes it. So if the patient goes off Flomax, the prostate gland's going to tighten back up and they're going to have their symptoms back. With the Proscar, it actually decreases the size of the prostate gland, so if they stop their Proscar, their prostate gland will start growing back, but it's a very, very slow process, so it'll be a long time before they see symptoms back. Flomax works within about a week or two, making it a little bit more desirable than the Proscar, and the only thing this drug treats is BPH. I don't believe it has any other indications. Some of the adverse effects come from blocking that sympathetic nervous system and vasodilation, the headache, from blocking norepinephrine, the fatigue. And then the other big thing with this drug is it's really well known for its first dose phenomenon. What that means is the first time a patient takes this, they may experience profound side effects. And it's typically like a syncope. They stand up and they feel like they're going to pass out. It should only occur with the very first dose they take, none of the subsequent doses, and we call it first dose phenomenon. So just the first time they take this medication, be on the lookout for that. Otherwise, it's pretty well tolerated. And we're to our very last male drug, and that would be Viagra. Yep, that one. How this guy works is it inhibits the action of phosphodiesterase, which inhibits the action of that enzyme, and it results in a chemical buildup of cyclic guanosine monophosphate. Now that buildup results in a relaxation of the smooth muscle within the corpora cavernosa, and all that really means is it's a vasodilator. It's essentially a vasodilator. It is dilating the blood vessels, which allows them to become filled with blood, and then it allows an erection to happen. So all that fancy termination for saying it's a vasodilator. This is the reason why if you ever listen to, and it doesn't matter if it's Viagra, Cialis, any of those ED drugs, they will say take cautiously of taking anything for chest pain, nitrates. They'll have a phrase like that in. And the reason why is those medications are also vasodilators. So if they're taking a nitrate for chest pain and a Viagra for the bedroom, they're going to have potent vasodilation and they're going to pass out. So that's where that interaction, that's actually the reason why I bring this drug to light, is because that becomes a serious safety risk for patients. And again, I was just perusing an NCLEX book and I saw a question regarding Viagra and nitrate use, and essentially use with caution. If they're going to do it, use with extreme caution, and just be aware that they do interact with each other to cause potent vasodilation, which means they're going to have low blood pressure, which means they're going to be prone to passing out. A few of the other indications for Viagra, or the only other indication for it besides erectile dysfunction, is also pulmonary hypertension. And if it's used for pulmonary hypertension, it actually has a different brand name, but it's the same generic name. So that's your little tidbit there. Your side effects, hypotension, especially if they're taking another medication for hypertension, and nitrate is going to be the big one, but anything that causes vasodilation, and we'll talk more about that when we hit cardiac drugs, has the potential to interact with Viagra. Also, because it's a vasodilator, it's going to cause some headache and some flushing. And then seek medical attention for an erection lasting longer than 4 hours, because that does become a medical emergency. It can result in permanent nerve damage and permanent erectile dysfunction. So it is important that, although it's kind of funny and nobody probably really wants to talk about it, it is important just to know that from a safety standpoint, they can cause you to pass out. And if for some reason it goes into overdrive, it can cause nerve damage. So that's the takeaway for men and women's health for the day. Enjoy your evening.